Good afternoon, everyone. This is United Medical ACO. My name is Kemal Erkan. Today is January 7th. I'm here with Sean Donegan from United Medical. We are going to cover the healthcare-related news on our session. And today we are going to have two guest speakers from the state of Delaware. And mainly we are going to actually talk about the COVID-related cases. And from the healthcare facility standpoint, healthcare offices standpoint, what we can do, how we can help the state and our patients. So Dr. Rick Hong and Dr. Michael Colada, they're going to be with us in the next 10 minutes. So I'm going to go ahead and start our session. This is our year 3 with these sessions, and our goal is to keep it on a weekly basis as we did last year, and hoping that we can provide good information for everyone who's part of this. So we are going to start with our political cartoon. Sean, you covered this, right?
Yep. So, well, Happy New Year to everyone. I know it's been a couple of weeks since we had our last session, so we actually had a lot going on in the healthcare news since our last session, which was middle of December, because I know we were off for Christmas Eve that Friday and then our New Year's Eve. So yes, to kick off this session, we do have our political cartoons here. If you look at our top left one, it is obviously Christmas carolers, and the tune that we are singing here, it's the most deadliest time of the year. Obviously, they're taking a stab at the fact of all the new COVID cases and how the Omicron variant just saw an extreme surge across the nation as we approach the holiday season and New Year. So obviously, people are a little bit less jolly, as you see the guy saying he misses Andy Williams, probably more joyful tunes as opposed to the deadliest ones. Right there, with Joe Biden and the comment basically saying that it's going to be, very deadly with the new variants coming out. And then on the bottom right, they have the mask over the eyes saying that we didn't see the Delta or Omicron coming. So again, it's kind of the idea that, you kind of anticipated a surge, we anticipated new variants coming out, with the new vaccines, trying to combat these new variants. It's kind of, you can't say that you weren't aware that this was a possibility. So it's kind of just taking a stab at that, the fact that, not to be ignorant to the issue, but that obviously is a real factor and a real issue impacting the country.
Thank you, Sean.
Yep. Yeah, and then here again, with our global statistics, obviously I said it's been 2 weeks since our last session. So if you see the United States, we were in mid-December, it was around 123,000 of those new cases with the daily statistics as the average. But now it's looks like 573,000 was the new daily average. As you see, the numbers just way rapid increase. And here's obviously the graph to show that too, as you see that enormous spike as we approach the new year with the daily infection cases going up. And then again, our vaccination, it was a steady increase. If you look at the graph too on the bottom, it looks like it is obviously an upward trend, but it did start to plateau. The doses were going a little bit down as compared to the mid-December. They were a little bit higher. They were at, I believe it was like 1.2 million doses, and here is down to about 843,000 on the daily. So they were declining a little bit, but overall the uptrend on the graph in the long run, as you look at the holistic picture there.
So when we look at the overall country numbers, 206, almost 207 million people fully vaccinated, about 72 million people who have their boosters. And in Delaware, which is our main focus for these sessions, the total fully vaccinated percentage is slightly lower than the overall the US level, but the percentage of 18 plus is about 89.2, and percentage of total population with at least one dose is about 69.2. That's the entire population versus 18 plus population. And the fully vaccinated right now, 572,000 people with 227,000 with booster and 89,000 with partially vaccinated. So I'm going to actually invite our guest for today, Dr. Rick Hung, who was part of our session before, and Dr. Michael Collada. Dr. Hung is our state medical director, and Dr. Michael Collada is the chief physician. How are you guys doing?
Good. How are you?
Yeah, tired.
Tired, right?
Yeah.
So, well, thank you for being with us. Dr. Hung, you kind of, you know what we are doing from the beginning, because we were in contact with you and with your office since the beginning of COVID. I just want to give a couple of backgrounds on United Medical ACO, and I know we are sharing some of these on a weekly basis, but about 115,000 patients we serve at the primary care level. This is equivalent of more than 400,000 patient appointments, and we didn't actually lower that number even in the COVID time because we made the telemedicine available. And about with the specialists, more than 100,000 patients are receiving services. And I did actually just look at the numbers from the Q4 of 2019, 2020, and 2021. And as you can see, actually, our 2021 Q4 number actually is higher than the 2 years, 19 and 20. So the point that I have is that we are trying to make ourselves available, our providers available, and be available for our patients. And that's from the UM side what we do. Now, we are following on the test, daily test, since the beginning. Some practices, they do want to do it, but as an ACO, that was our decision that we wanted to do it. And I actually have our provider meetings now, that's on a weekly basis. So what happens in these provider meetings is when you kind of just go through the same information every week, it becomes like it's difficult to just repeat it. And then I do the weekly sessions, and also it's kind of like just repeating yourself and then not seeing what people are able to do, how they are changing. In the last 3-4 weeks, we hit like 50% positive rates on the PCR test. And that was kind of like, it was alarming. But then we also see the total number of cases in the country, how that number kind of increased a lot. And now I know the state numbers are a little bit different these days, but when we look at the total percentages of the positives at the ACO level, last week we were over 50%. So now what I would like us to do is a couple discussions and just get your, really, we are in this together. I'm not really, my goal is just to have the discussion in the best possible way that I can. So one of my concerns, as now many people are getting COVID, even they are fully vaccinated, and I'm a big believer of the vaccine, and we promote it from day one. Now, the 75% for the immunity, do you think that number is still the magic number? Like, because people are kind of questioning it, and we were about to get to that level. Like, is that the magic number for us? Like, do you think that's going to solve the problem?
So yeah, that's a good question. And I don't think there's really an absolute number. There's so many other variables involved that really determine spread of disease within the community. However, the vaccination rate is a key component to limiting transmission in the community. So I've seen 75%, I've seen 80%. So I'm not sure what the true magic number is, but definitely more is better regarding getting people vaccinated. Given the breakthrough cases, we're still seeing some breakthrough cases, that it's critical that people are not just fully vaccinated, which means you complete your initial series, 2 shots for mRNA vaccines and 1 shot for the J&J, but also you should be up to date with your boosters.
I see. And like one of my answers to, how those people who didn't want to be vaccinated, what I used to tell them, and what I still tell them, vaccine doesn't have 100% efficacy. So the best one is about 90% anyway. So there's always that 10% that's not going to work out regardless. But I think what we see now with the number of total cases, that's going to take me to my next point. So total number of cases, it's almost like a joke, because if this was to happen in the beginning, we would probably just have a heart attack. But now what we see is, it was, I think the 7-day average was 740,000 2 days ago. And I didn't actually check this morning because it was depressing. And now we have these really big numbers. In fact, today, if you were in my office, you wouldn't be able to see it. Half of my staff is not here. So at least 10 of our providers have COVID, either COVID positive or they're exposed to COVID positive patient. So, and I keep telling people that, well, if we didn't have the vaccination, then we would be in a really bad shape today. Now, I'm not a physician and you two are. So if you can just share your opinions on the total number of cases being so high and how this is being handled these days. How are we doing?
Yeah, and I appreciate you mentioning the fact is that the vaccine is not 100%. We don't want people to think, oh, we're seeing breakthrough cases. That means the vaccine's not working. The main focus of the vaccine is to protect people against severe burden of disease, specifically severe illness, hospitalizations, and death. So we are definitely seeing, although we have the increased number of cases, we're not seeing a parallel increase with hospitalizations and deaths, which is meaning that it is working. We're also seeing the majority of hospitalizations and deaths are those that are unvaccinated. I don't know, Dr. Claudia, you want to add any more to that?
Yeah, usually for vaccine efficacy, I too, I'm a believer in the vaccine. I'm a believer in the getting boosted. Science has shown us that getting boosted is definitely the best protection against the new variants, including Omicron. The way I generally explain it to my patients is I compare it to a seatbelt. When you're driving in a car, a seatbelt is not going to prevent every single injury that happens in a car accident. However, it is still your best defense against injuries. And so that's kind of how I compare the vaccine. Is the vaccine is your best defense against COVID-19, serious complications, including hospitalization and death. And the booster is certainly something that is going to further protect you.
And again, I think if we didn't have this many people vaccinated, I think we would be dealing with a big nightmare today, because with these number of cases, and if it was at the same rate that people were going to the hospital, we would be, I don't know how we would be able to handle it. So now, if we can talk about the variants and what we are expecting, what's happening with the Omicron today, and if we know what happened with the Delta, and are we expecting anything new in the upcoming days, any new variant, and how the state is working with these changes? Like, how do you guys actually prepare us for these changes?
Yeah. So, variants occur, no surprise, due to mutations that occur in the viral genome, and Omicron definitely is the concern right now. Current data are showing that the Omicron may not be as severe as Delta or other variants, but of course it's still impacting our healthcare system overall, because you can see the number of cases are going up, including hospitalizations. So it definitely has an impact. We are hearing other variants happening. I don't know if you guys are familiar with one coming out from France. I think the name is IHU. So that's something that, folks are keeping an eye on. The concerning part of this particular variant, again, the number of mutations. The more mutations you are seeing in the genome, the more concerns that's going to cause a greater impact within society. Might have more resistance to vaccine and other issues, concerns with variants and their mutations. So, we are working closely with the CDC to kind of keep an eye on variants. Our public health lab performs genomic sequencing, which helps identify certain variants. So we're working hard to kind of get an idea of what actually is happening regarding COVID. So we're not just testing for positive or negative, but we're trying to figure out what exact strain we're seeing. And we are seeing more and more Omicron as days go by.
To add to that, as far as what Delaware is doing to try to help protect its constituents, we are doing everything that we can to try to make vaccines as available as possible. We have plenty of vaccine, and we're doing everything that we can to try to promote the vaccine, make it available, and as streamlined as possible. Unfortunately, testing is is a bit of a shortage nationally. Delaware is doing pretty well with testing, but our goal is to not necessarily promote testing, because testing doesn't prevent disease. It helps with outbreaks. But really, the vaccine and the booster is what we are trying to promote, and that's what we're trying to maximize efforts in order to get as many people vaccinated as possible.
So, Dr. Hang, you mentioned France. Actually, it's interesting because when I'm providing the number of cases, now the provider meetings on a Thursday night, every Thursday at 6 p.m. So I opened the Worldometer. Usually I go with a couple different places, but let me actually just bring that up. And France was extremely high, I think maybe 6-7 days ago. And then, as you just mentioned, they are having the new variant that I just opened to see where they are today. So they already reported 328,000 new cases. These are 7-day averages. And then the day before, they were at 261, and then 2 days ago, it was at 332. What's happened? Like, as you know, I'm from Turkey, and Turkey is number 7. France was actually below Turkey, I think maybe 9 days ago. And then now, in the total number of cases, now they are 2 up, and being in the top 5 is not a good thing, unfortunately. What do you think is happening in France?
Yeah, it's hard to say. I'm not familiar exactly the details what's going on, but again, whether the variant has anything to do with that, I'm sure it has some impact with that. It's so difficult to kind of gauge what impacts cases. It's not just the type of variant out there. It's also how infection control measures are being followed by the population. Also how access to testing will impact also the ability to diagnose new cases. So it's hard for me to make a comment specifically on France, but we are concerned that the variant has a role in that.
Dr. Coletta, do you have any?
Yeah, again, this new variant, IHU out of France, is so new. I don't think we know enough information about it to say whether or not it's contributing to new cases. We can certainly speak to Delaware, but I can't speak to France's numbers.
So I wonder if it has something to do with the vaccine protest. So like in the last 2 months, they were out and about and just protesting the vaccine in public. But I guess more to come from that. Now, the other thing that we have is the pediatric population. And this was kind of like touchy in the beginning, although like pediatric population is used to the vaccine more than the adults, but this new one wasn't welcome as well. How are we doing with the pediatric cases these days?
We are definitely seeing increase in the pediatric cases. We are focusing hard on trying to get more kids vaccinated. As you know, they were eligible much later than adults. So, you're not going to expect to see the numbers that we're seeing in adults, but definitely a lot of room for improvement regarding vaccination in this population. We're working closely with partners within the medical community, pediatricians, family medicine, et cetera. Also, working closely with schools to help with vaccination efforts.
So right now it's only Pfizer that's available for the kids, right?
Yep. So the booster in particular, the newest update regarding vaccination allowances. So CDC and FDA both approve boosters within the age population 12 to 15. Again, this is Pfizer only. And it's good timing because of when the 12 to 15 population age population was allowed to start getting vaccine. We're around that 5 months range. And also just want to add that the booster interval went down from 6 months to 5 months.
Yes, right, actually. Now, one of the other things with the while the COVID started in the beginning, one of our issues was we were trying to collaborate with the hospitals. So I do have other than the ACO, we have a surgery center. Mm-hmm. American Surgery Center. And because we stopped doing cases for about 5 weeks in the beginning, I reached out to all the hospitals and asked them if they need any resources. We have 3 ORs and ventilators. Now we are in the middle of getting another surgery center license in the Bexwoods area, in this Bear area. And one of the things with the need assessment, like the certification of need, which during this COVID trouble that we are going through, it made it more clear to me that we need more ventilators available in the case of what's happening today and what was happening since the beginning. Do you think state would change its position on the certificate of need for the surgery centers? Like, how can we actually, can we argue that we don't need more ventilators available? It's almost like.
Yeah, so it sounds like it might be 2 different things. You're asking about our supply of ventilators, and then you're talking about certificate needs for additional surgery centers, correct?
Yes.
Yes, I can't speak on the surgery center. That's not within the Division of Public Health. That's within our Division of Healthcare Quality. So, but we do understand why certificate needs are there, because we want to make sure that the resources are available and not compete with one another. So if there's a need for additional resources, again, the certificate need process is there to identify any gaps in access to care. In terms of ventilators, we heard other jurisdictions within this country and also within the world requiring more ventilators. In Delaware, there was not an issue, though we do have a stockpile of ventilators. We did work closely with the federal level to get additional ventilators in case we need it. So fortunately enough, we never needed to tap into that resources, but we were prepared with additional ventilators if the time came.
So just from the clinical standpoint, one other thing that, again, when we are going through this, we have 22 different specialties other than the primary care. So bariatric surgery is one of our specialties, and in the surgery center, we do that. Now, I'm not on the surgery center side, but I'm just a little bit concerned about the way that we are treating or like labeling the surgeries, like the elective cases. I understand it's not an urgent case, but any of these cases, as they are being delayed, they are more problematic for the patient. And especially like patient with obesity, it's about 65% of the COVID positive cases are either obese or has either obesity or morbid obesity. So I'm having a little bit difficulty to follow the postponing the elective cases. Now we are doing a much better job with the limiting the number of patients that we are taking care of, and with the visitors and all the other stuff. But what is your personal opinion on? I understand division may not have anything to do with the surgery centers, but do you think elective surgeries should be postponed? Like this can be hernia, this can be gallbladder, this can be bariatric case.
Yeah, so we can't comment on that because again, that's a medical provider decision. We do want to support the healthcare continuum, however we can, but that's an operational decision on the facility end, whether the need to cancel elective surgeries there due to limited resources, and again, prioritizing those limited resources to what is critical versus maybe not as critical. So, as you know, elective surgeries were canceled initially when there were PPE shortages, staffing concerns as well. So, each facility made its own decision whether to cancel elective surgery or not. We did not mandate cancellation of elective surgeries because, it's hard for us to get involved without understanding the operations behind the delivery of healthcare. So again, we appreciate our partners within the community to make those hard decisions. There's a lot of variables in play when you're making decisions to decrease healthcare services, which may include elective surgeries.
So, well, thank you for that. And really, like, I wasn't really trying to give you a hard time with that. It's just like we go through with this. I talk to my providers and we have the discussion. Sometimes in the media, it's reported differently. If these are just elective cases, like you don't elect to get like gallbladder surgeries. Like it needs to be done. I mean, nose job maybe, but not the not these cases. And what I see is, especially now we are going into the third year, more complications are coming out from these populations. They are I can speak on the obesity side, patients are getting heavier than before. So now the complications are, or getting them ready is more complicated from that point. Now, I will ask this for both of you. From United Medical ACO standpoint, we are here to help our patients, but we are also we are well aware of what we need to do with you guys and how we can work together. Anything that we can do to make your life better for patients and the population in Delaware?
Yeah, and Dr. Coletta actually works with one of the hospitals here in the state. I think talking from the state perspective, trying to keep as many services open as possible, which may lead to protecting your staff to make sure they're healthy to be able to still provide that care. We also realize that President Biden has that mandate for vaccinations for healthcare workers within CMS facilities, because we do feel that the vaccination may help protect the healthcare workforce. So we appreciate the commitment from our healthcare partners, during these hard times, still continuing to show up to work and deliver care. So we really want that workforce to be very safe and healthy as much as possible, and try to maintain those services and keep them open. But I do understand the challenges with staff shortages and hard decisions need to be made. Just also from update standpoint, the CDC did provide changes in the isolation and quarantine for healthcare workers. So, they separate scenarios from, your conventional scenario to your contingency and crisis. I think it's very helpful to break down those scenarios to help guide healthcare facilities on how to manage staffing. As long as providers still continue to protect themselves with vaccine, PPE, also want a reminder that, protecting yourself is not just at the workplace, because, the community spread is so high that there is a risk every day and outside the work place. So, it's great that you maintain social distancing, you're wearing your mask at work, but you also have to consider infection control measures outside of work. Dr. Coletta, anything else to add on how we can work together?
No, I would just echo everything that you said.
Yeah, and I just also want to just add in there the stressors on emergency departments as well as EMS 911 services. That we want to remind folks to use these resources appropriately. If you think you are having an emergency, then please call 911 or go to your nearest emergency department. But we're also seeing a lot of panic out there, and our emergency departments are seeing patients who are showing up just for a test. We do have a lot of access to testing, and I know there's some urgency to get tests done, but we also want to remind folks that emergency departments are there for emergencies. So please use appropriate judgment in determining what resources to use. And it's great with your ACO and other partners to maintain those services and be available, whether through telehealth, on-call system or something, if your patients are in need for medical advice or some level of care.
I think a lot of people are, you're absolutely right about the panicking. So it's the flu season. We would normally have the flu anyway. And then now everyone who is sneezing or coughing, they think that they have COVID. So I was actually one of the first COVID people. It was April 2020. And I really thought I was going to die. So, and I was still doing what I was doing every day, but from home, and employees were at home. And that time I didn't know it was going to be okay. So, but now we know that vaccine is out there. People should be taking advantage of the vaccination, but also not every cough or every sneeze is COVID. So they should be still careful. I think the mask use we got a little bit loose about the mask in the last, maybe like in the last week it changed. Well, including myself, we were kind of just like, we were okay. So I was really isolating a lot from social events. But 2 months ago, I went to New York. I couldn't believe how crowded it was. 6 months ago, I was in Philadelphia. People were kind of crazy out. Like they are kind of like fighting COVID in a different way. They were kind of challenging COVID. So I think the mask is really the key these days. But you are, in terms of the utilization of the resources, you are absolutely right. Because we see number of cases, number of tests being up. And in some cases, they are just, oh, I just want to double check. But we really need to be more precautious with the mask and others. Now, one last question, and I'm asking you a lot of questions that I'm struggling with. So maybe you have a better answer. That's why I'm asking. So if you are trying to convince someone for vaccination, what would you tell them? I mean, I said a lot of stuff that didn't work.
One of the biggest things that I've found that's helpful is trying to understand what their hesitancy to the vaccine is. Perhaps it's just one piece of information that or like one question about the vaccine that they need answered. So I typically just ask them, what is it that is creating this hesitancy, or what questions can I answer for you about the vaccine? They say, well, I just don't understand how mRNA vaccine works. I give them a brief explanation to them in the way that they can understand it. And sometimes I find success and patients will say, okay, that's fine. I'm okay to get the vaccine. Or it's just a bit of misinformation that they heard on the internet. They said, well, I read that if you have an allergy to this, you can't get it. You just re-educate, you say, no, that's untrue. The vaccine is very safe. It's very effective. They say, okay. And then they're willing to get it. Sometimes it's just a very simple question that they need answered. And sometimes getting it from the medical community is enough for them. I've also found that there are some people who are a little bit more resistant to any type of re-education or trying to tamper down on some disinformation. And with those, it could be a little bit more challenging. There are some people who are very set in their belief systems and set in their convictions. So it has been challenging to vaccinate everybody. But I do find that there are a lot of people who are still very willing to have a conversation, at least about it. And a lot of the times it's just a question that they need answered, just like one small thing that they're kind of hung up about.
Well, I tried so many different things, trying to put the emotional pressure on them too by utilizing their family members, but sometimes it just doesn't work. So, guys,
shown that family and doctors have been or I guess I would say healthcare personnel and other family members are the most influential in trying to get people vaccinated. Obviously, nobody wants to try negative reinforcement, and a lot of the times, even just like media projections aren't enough to convince people. But other family members and healthcare personnel have definitely been very influential in the vaccine movement.
Well, yeah, I mean, I think it's some people do have an issue with the trust in the medical system. So, and my argument always is, look, our providers, our physicians, they got the vaccine first. So if it wasn't safe in the beginning, we weren't going to risk the workforce in healthcare, right? So, and then they were not going to get this done. So I put about 10 or 11 providers together on a video. They talk about their vaccination and why they got vaccinated. And we want more people. My both parents, my dad, he's 81. They're actually visiting this week. Like they're from Turkey, and he has 4 vaccines already, 4 doses. And he's like, if there's another one available, I'm going to get it. So, there are people who are really open and trust, and there are people that are not trusting. And my issue with that is, we don't want them to be harming themselves in this process. And because once it's late, it's too late. And that's not what we want to see. And I know you guys are busy, and then I know you were available for this in a very short amount of time, and you spent a lot of time with us. Thank you so much. And I just want you guys to know that we are here and we are available for you. And I know that when we have issues, we come to you all the time. So if there's anything we can do, let us know. And thank you for joining us today.
Absolutely. Thanks for having us.
Thank you very much. Take care.
All right, so Shahan, you can come back. So it's about 2:40. Beste, you can join us. What I'm thinking is, let's see if Beste is able to join us.
Hi, Kemal.
Hey, So what I'm thinking is we should do your session next week.
Okay.
It's because I don't want to rush it, and it's important. So for our audience, we do want to share this with them. So every other week, we'll rotate clinical and RCM, the medical billing related items. And Beste did prep for RCM side for today's session, but because it's going to be, well, I'm thinking maybe should we do it? It's actually 2:39.
Up to you.
Yeah.
I was going to talk about HCC RAF scores on corrected claims.
Yeah.
I can briefly go over it.
Yeah, actually, let's do that. So because I thought it was 2:49 for whatever reason.
It's 2:40 now. Mm-hmm.
So here I'm gonna bring that. All right, so Beste is one of our senior client managers. She's gonna cover the corrected claim and risk score process. This is actually medical. On one side, it's on the medical billing, but on the other side, it's also clinical. And both departments are working very closely with this item. So, all right, Beste, you're on.
Okay, thank you. Hi, everyone. We wanted to cover the HCC's hierarchical condition category coding, risk adjustment factor scores for patients, and how the billing departments assist in sending corrected claims in the process. So HCCs are basically defined by CMS and has been in use since 2004. They're basically originally designated to estimate future healthcare costs for patients. And along with the basically demographics of the patients, insurance companies use HCC coding to assign patients a risk adjustment factor, which we use as a RAF score. And this helps in predicting healthcare resource utilization and costs. Well, at United Medical, our care coordination department does routinely pre- and post-visit chart audits to identify any missed HCC coding opportunities. And billing team, on the other hand, ensures that we send corrected claims in a timely manner with those updated diagnosis codes. So that we basically ensure that patients' RAF scores are updated in the insurance system to appropriately reflect their risks. In 2020, we sent over 5,500 corrected claims for this reason. This is actually a very simple summary of how we are capturing the risk of the patient. The example I had was from a presentation by AFP. This is a patient, 68 years old, diabetic, with polyneuropathy, morbid obesity, and congestive heart failure. And we are just in the first scenario, assuming the provider only coded the diabetes, hypertension, and BMI of 38.2, as these are like just the basics of covering some of the diagnoses, chronic basically illnesses the patient has. In this case, the risk adjustment factor for this patient ends up to be 0.427 in the insurance system. So it seems like this patient is not very risky because we are not really capturing and reporting the full picture. But on the other hand, in the second scenario, if you are coding actually everything that the patient presents as a chronic disease, which includes diabetes, the polyneuropathy, hypertension, morbid obesity, along with the BMI and congestive heart failure, then we see that actually the risk factor for patient jumps up to 1.3, and we are correctly capturing the risk of the patient.
So
Well,
in this one, so this is kind of like a before and after, right? This is like the, although we are talking about RCM, Your revenue
Well,
cycle
this is
management?
just an example. Yes, this could be maybe initially it was coded with missing diagnosis codes. And the second scenario is actually the optimized scenario, which is all the chronic diseases for this patient is captured in the diagnosis coding.
Sure. So what I was going to say is that, like, although we are approaching this from the RCM side, we are really helping the clinical side as well, because when we bring these issues up, these are being addressed by the providers. And therefore, next time when the patient comes back, they are more careful with the problemless side of the patient with the chronic illnesses. So then they can actually, while they are capturing their risk accurately, they can also document better and address those problems better. So that's one of the big problem these days. The morbid obesity treatment for morbid obesity is so bad in a way that it's almost like a taboo. Although, like, we do Friday sessions, perhaps Friday for this. When we do the chart review, we find out almost 85% of the time patients with morbid obesity is not getting proper treatment because patients are not bringing that up and the providers are just kind of shy about it. So although, we are, again, doing this from your department, the RCM side, but it does have a huge impact on the clinical approach. And then I see, I'm expecting better changes in the next several months.
I agree, and I really enjoyed that you cover all those topics more in depth in your bariatric Friday live sessions. You will have one more after this one, right?
Yeah, we have another one today.
You'll be joining.
Yeah.
So yes, and you are right. From billing end, we are also helping the clinical side, and that speaks to the teamwork efforts. So in order to optimize risk score reporting, teamwork is really one of the crucial points because it doesn't end with the provider seeing patient. It is posting the charges, everyone at every level, like from nurses to post-visit chart audits to the billing team. It's a really teamwork, and there is a need for a solid understanding of HCC and showing ownership of this process. And definitely, as needed, there should be training at all levels. Beyond that, obviously, appropriate diagnosis coding at higher specificity level is crucial for correct reporting. And that's what we are trying to do as a team. And obviously, also supporting these diagnosis codes with clinical documentation properly, which this is more on the provider end, I would say. And beyond that, it's about data management. We are looking at patient data. We are looking at claims data. It involves all parties utilizing the workflows effectively, and obviously the systems. And here I wanted to include the AAA again, because this speaks to it very closely. We're trying to lower the cost of care for patients while providing improved quality care and increasing the patient experience, and also improving the population health.
Absolutely. So what's the impact to the providers for their bottom line, though? That's going to be important, right?
What is it again?
What's the bottom line impact to the providers?
Yeah, I think it's both ways. This system also helps them, because I know especially care coordination team doing the audits, they do point out, like with flags, whatever diagnosis was missing maybe, and those will be definitely covered during next visits. So that's very crucial. And finally, I want to talk about just highlighting the importance of risk score reporting optimization. It does mean we are trying to improve the patient care, and it does speak to this. And it returns increased revenues and also increased staff satisfaction. This was again taken from an AFP white paper on this subject. The first group here, Kemal, is a group of patients in primary care with HCC lower than 1.2. You can see yearly, this primary care population base payment is at around $100,000 versus the second group is actually, we are assuming they more appropriately captured the risk of their patient population, and the payments they receive for the same population actually comes up to $160,000.
Absolutely. So, one of the triple aim point that I have is in healthcare, when you just focus on the clinical side, on the quality, quantity follows that. So the financial part, financial reward follows it. So right now, many of the projects that we are working is being utilized as a model for other ACOs with our clinical integration. And what we have done in the last 6 years, it is now being a model for other ACOs, and we are proud of that. And we are happy that we are actually able to contribute differently to the medical society. So, well, this education is helpful because part of this session, we are trying to reach out to our patients, but we are also trying to reach out to our employees and our providers through this. And when we cover these types of sessions, these topics in these sessions, it does get their attention in different ways. Now, we are gonna, Bessie, you can stay, and Sean, you can come back and we'll close. So I'm gonna, one of the new stuff that we adopted since Sean started is the books that we are recommending. And another good book in the United Medical Library is Stephen Covey's 7 Habits of Highly Effective People. So because of the time that we have, so Sean, what we'll do is we'll go through those 7 items at the next session. So then you can finish the book, because I know you didn't read it yet, right?
You caught me. I have my bookmark in there though. Halfway.
I know the best already had read
He has it memorized, she told me.
So we can go through those 7 items next week, and then we can properly cover why we are actually recommending this book. Certain things that I think, just to kind of tell you from my point, it's all about the discipline and understanding that discipline is not a negative term. Discipline is a good quality. And when you go through this book, you're gonna see everything that we are trying to do. There has to be some routine, and then that has to be part of your culture, daily culture. And those habits are really just part of that discipline, and how that discipline can be established in time. And I think we can spend some time on that next week on the session that we are going to have. Well, guys, thank you so much. This is our first session of 2022. And as we promised, we are going to keep this on a weekly basis. And we already have our topics distributed for the first quarter. So anyone who wants to be part of it, they can always let us know. And we are going to still host either providers or other state officials related to healthcare throughout the year. Well, thank you for joining us, and we'll be back in 10 minutes or 7 minutes with Bariatric Friday. See you soon. Bye-bye.
Thank you.
Take care. Bye-bye.